right, so I'm going to give the rest of the lecture about traumatic cardiac arrest. I don't really need to introduce myself because you guys know me. So historically, as was mentioned earlier in QA, traumatic cardiac arrest has poor survival. Now, a lot of that came from literature done in the mid to early 80s, going through the 90s, and it was centered mostly in either very rural spots or in densely populated urban centers. And they were citing survival rates of somewhere less than 1%. In some studies, they had a 0% survival rate. But that was also quite a long time ago. So now we've kind of revised our approach to traumatic arrest. And a lot of it's been driven by the trauma surgery and the acute care surgery world. And they've developed guidelines as to who should get an emergent thoracotomy, which is what Dr. Jones is talking about, where they actually open up the chest and address some of the life-threatening interventions that only a physician can do, like cross and clamping the aorta or clamping some of the lung parenchyma for a pulmonary contusion or something like that. But surprisingly, traumatic cardiac arrest has a parity for survival rates with medical arrest. Nationwide, it's somewhere between 5 to 7% of traumatic cardiac arrest will survive. In some areas, that is actually much higher. London, England has a traumatic cardiac arrest survival rate of about 50%. Now that is because they are physician staff helicopter EMS service, and they have the ability to do like resuscitative thoracotomies or REBOA and other therapies on scene. So that's an important confounder. But the main gist of it is these people aren't as hopeless as we may see. And a lot of that is being driven now by an initial resuscitation bundle, for lack of a better word, of we're going to do X, Y, and Z interventions first and then reassess. If they don't respond, they're probably not going to live. If they do respond, and we'll outline what those parameters are, we may be working with something. So typically we divide traumatic arrest into witnessed and unwitnessed and blunt versus penetrating trauma. And one thing I will say is to maintain a high index of suspicion for a medical arrest when the trauma doesn't appear to match the arrest. So if you have someone with a low speed MVC at like 10 miles an hour, but they're 75 and they're in cardiac arrest, is that traumatic or is that medical? Well, you can't really know without more information. But with the arrest that's out of proportion for the trauma, think medical. So our witnessed arrests are going to be those who either witnessed someone, we watched them arrest. So we picked up a trauma patient and they went into arrest while en route to receiving facility or shortly after we got on scene. These folks have a much higher incidence of survival than your unwitnessed arrest. And some guidelines even parse this out a little bit, is if they had loss of vital signs with bystanders. So they made a call, like Jim Bob's been shot. Yeah, right now he's breathing and he's talking to me. And then 5 minutes into it, dispatcher says, hey, the bystander says they've lost pulses. And they're starting CPR. That's actually an encouraging sign. It's not really because they're in the process of dying, but from a survival standpoint, we have more to work with at this point. Some of these people will be candidates for surgical intervention. Theoretically, every ED physician is trained to do a resuscitative thoracotomy in an ER. However, that's going to be highly variable on the facility that you transport to. I don't know if St. Joe, some ERs I've been to don't even have the equipment to do one. So I don't know if they would do one unless they were presented with a very pressing case. Yeah, I don't want to say they wouldn't because that's kind of bleak, because you might get someone who'll do it. But if you have a trauma patient who arrests and you're 15 minutes out from UK, they're a candidate for a surgical thoracotomy the moment you get to UK. They will go there, they'll open up that chest. And that's for blunt or penetrating trauma. Because historically, we've all been taught that people with blunt traumatic arrest don't live. That's not entirely true. It still maintains that survival parity with like medical cardiac arrest and stuff like that. And that's also predicated on having access to good surgical intervention, which we don't have. So we're going to have a lower incidence of survival based on our geography from a trauma center. But the driving point is don't write these people off. Do the initial care bundle we're going to talk about and then reassess what's going on. So your unwitnessed arrest, if they're unwitnessed and they're asystolic on arrival, regardless of other factors, they're highly unlikely to survive. And if they do, it's almost certain that they're not going to have a meaningful life following. Their CPC score is going to be high. So they're not going to have good neurological recovery. Some of the guidelines, we cannot necessarily withhold resuscitation if it doesn't meet the KRS. But some of the guidelines, like the National Association of EMS physicians and the American Academy of Trauma Surgeons or something like that, put together a joint position statement that said, here's a fairly short list of situations where you shouldn't initiate resuscitative measures because these people will not survive. So usually it's things like no vital signs, they're asystolic, you have no pupillary reaction, stuff like that. They're like, don't worry about it. That's a little bit more progressive than Frankfurt's letting us be right now. But just know, if you have an unwitnessed arrest and they're in systole upon arrival, they're probably dead. And they're probably going to stay dead. And as always, in a mass casualty situation, these patients are going to triage as expectant, and you're going to roll on because they're going to take too much of your time and resources to really treat effectively. So like I already said, historically associated with poor survival. The thing with blunt trauma is you want to consider commotio cordis and traumatic asphyxiation because that's actually lumped into the blunt trauma archetype. So these patients may be responsive to aggressive initial airway management and oxygenation. And does everyone remember what commotio cordis is? Anyone? Well, it's essentially Latin for irritable heart. And your classic example in PALS class is that 8 to 9-year-old who's at Little League and gets thumped in the chest with a baseball, and that causes a cardiac arrest. That is technically a traumatic cardiac arrest. But those patients often present in VF or VT and can be defibrillated out of it. So those patients have a much higher incidence of survival and good neurologic recovery than your patient who runs into a guardrail on I-64 at 95 miles an hour. So as always, consider the clinical context at which these events happen. Does that kind of make sense? Okay. So your penetrating trauma, your classic ideal surgical candidate for thoracotomy is someone who has isolated penetrating trauma to the thorax with a witnessed arrest. These folks generally have better rates of survival because the damage isn't as extensive necessarily. So if you have a blunt traumatic arrest, you can infer that they're probably going to have a lot of damage inside of their thorax or through their abdomen to their pelvis. They're going to have multiple surgeries or multiple points of resuscitation versus a single gunshot wound to the chest. Hey, we can kind of figure out, because bullet trajectories inside the body are really unpredictable, but we can have an educated guess as to where this bullet traveled and to the structures that it may have encountered along the way that would have caused this arrest. So an aortic cross and clamp or something of that nature. And Dr. Jones, feel free to interject at any point. So these are your best bets. And the military has actually shown that service members, now this is a confounder because they have access to very aggressive surgical care in a fairly accessible amount of time. They don't necessarily, we're not like transporting to St. Joe, 30 minutes from outside in the county, right? They're not going to have a surgical team there waiting on us. But in a military setting, you could have a comparable distance, but be transporting to places that have surgical capability, at least for what's called damage control resuscitation, which is really focused on high yield. Hey, crack the chest, do all the stuff that we know is probably going to work, and then ship them on. But there's military members that have survived extremely high, what's called an ISS score, which is injury severity score. So they have like ridiculously high ISS scores, and they arrest. But then they have recovery and meaningful recovery. So they're neurologically intact and stuff like that. But that's also the military setting and not necessarily what we're going to encounter here in Mount Sterling. So, and these are your folks where if you have isolated penetrating trauma and you have a recent or witness loss of vital signs, those are your guys where you might want to load and go and start motoring towards UK and then do your interventions en route. Or go here, especially if you suspect cardiac tamponade, because they should absolutely be able to do an ultrasound-guided pericardiocentesis. And that's a high-yield intervention. Now, I keep saying high-yield intervention. Is CPR and traumatic arrest a high-yield intervention? Probably not, right? Because all of our pathologies that we encounter cause traumatic arrest aren't necessarily going to be helped by closed chest compressions. In fact, some of them might actually be worsened, like a cardiac tamponade. So that's not to say you don't do CPR in a traumatic arrest. It's just to say it doesn't make much physiological sense. So instead of initially hopping on a chest, maybe what we should do is alter our priorities and do things that we know will work initially and then go back. There's some physicians out there who advocate the concept of what's called a silent chest in traumatic arrest, meaning that there's no one doing CPR while they're in the initial stages of traumatic arrest management, because that frees up time and it actually makes it safer for providers to do things like tube thoracostomy, airway management, pericardiocentesis, and other stuff like that. So it's not to say that CPR is useless. It's not to say that you shouldn't do it. It's just in the initial stages, it could probably be de-emphasized. Now, if you have 10 people on scene, sure, why not? But if it's just you and your partner and you come up on that and you're the first people there, then pull them out, do what are called hot interventions, and we'll go over that here in just a second, and then start your CPR. So these are the killers in traumatic arrest. These are pretty much the origin of most of your traumatic cardiac arrest, or hypovolemia from hemorrhage. And that could be just massive hemorrhage. You blew out an inferior vena cava, or you blew out your aorta because you took a 38 to the chest. Now you have 2,000 mLs of blood sitting in your thoracic cavity. That's definitely going to be hypovolemic. But it can also be from other things, like a pelvic fracture. We all know how much you can bleed inside your pelvic area. So if you bind that pelvis, pelvic binding is a form of hemorrhage control in the traumatic arrest. Your oxygenation, so this goes back to strangulations, traumatic asphyxiation, and if they have like an airway disruption or something like that that causes like massive maxillofacial trauma. Maybe they're a candidate for using a quick trach or aggressive intubation or something like that. And that's also not to say that intubation is the end all be all. It's not. But in the patient that doesn't have severe maxillofacial trauma, but you suspect maybe they were strangled or something like that, or they were hanging, if you place a king and you have good return and you have efficient ventilation, that is better than nothing, because the cause of their arrest is an occluded airway, traumatically occluded airway. And then your tension pneumo. We should be doing empiric bilateral needle chest decompressions on all of our traumatic arrest patients, because we should suspect it. In some of the studies, when EDs received traumatic arrest, they had ROSC in about 20% of the patients when they did a simple needle thoracostomy. So it's a very high yield intervention. It's very easy to do, and angiocasts are like $2 a pop. So, I mean, just go ahead and do it, because honestly, you're not going to harm that patient, because it's a good rule in, rule out, right? If you decompress the chest bilaterally and you get blood or air return, that's a rule in. That patient had a tension pneumo, or they had a hemothorax, or they had a hemopneumo, right? If nothing happens, okay, we've kind of, because we don't have ultrasound, ruled out the possibility of a catastrophic tension pneumo. And that's useful information if we transport to relay that to the ED physician. And then cardiac tamponade. It used to be, and I don't really think it's in anyone's protocols anymore, that paramedics could do pericardiocentesis in the field.
Not in Kentucky.
Let's say not in Kentucky. My dad talks about, like, way back.
In Texas, yeah.
But that's another high yield intervention. And if you suspect cardiac tamponade, that patient is a good candidate for transporting them rapidly to the ER so they can perform a pericardiocentesis. And all that is taking a big needle, advancing it in usually under the xiphoid process left of the sternum, and puncturing the pericardial sac and aspirating some of the blood that's collected around it and cause that obstructive shock.
And let me interject there. If you do that, if you get 2 or 3 cc's, that oftentimes is life-saving. You don't need to get 30 mLs off there, even if there's 50 or 60. If you just get 2 or 3, that often reduces the pressure to where the heart can function much better. It's just amazing.
And that's a low-cost, high-yield intervention.
But you can't do it.
Yeah, it's kind of complicated things. But addressing hypovolemia, if they have any sort of external, like massive external hemorrhage, you need to aggressively control that. So that's placing your tourniquets If they don't have a wound site that's amenable to tourniquet placement, so neck, axle, or groin, pack it and put pressure. We carry Curlex. Curlex is probably the best agent for wound packing, and it's comparable to things like combat gauze or other hemostatic agents if you know how to pack a wound correctly. There's actually no difference in the time to stopping bleeding if you take someone who's proficient at wound packing and they pack with combat gauze versus packing with Curlex. So rapid vascular access, preferred above the level of the diaphragm. I know we can only do tibial IO right now, but humeral head IOs are pretty much objectively superior to the tibial IO in every way. It has a very similar uptake as a subclavian central line. If you ever get to do a Teleflex cadaver lab, they'll actually demonstrate this for you. They'll do a cut down of the subclavian, allow you to place a humeral head IO, and then when you push the fluid through, almost immediately you'll watch that subclavian engorge. And that means you have fluid going directly to the heart. So it's not having to go through some more of the systemic circulation, or that may have disruptive processes, right? We may have fractured our femur, we may have fractured our pelvis. So we're not entirely sure that all that fluid or even any of the medications that we may give actually reach the heart. So your humeral head IO is a better way to ensure that the fluid boluses you are giving is actually going to hit its intended target. Bind the pelvis, we've already talked about that. You can bleed a metric crap ton into your pelvis. So if you bind it, we actually have pelvic binders on our trucks now. So bind the pelvis empirically in all of your traumatic cardiac arrests. It's an easy thing to do, and it's a critical intervention. Straighten your long bone fractures, so straighten out your humerus, straighten out your femurs. It may help. Not nearly as high yield as binding the pelvis, but it's still a good thing to do. And then administer your IV boluses. Generally, we're taught in trauma, be fluid restrictive, and that's typically okay for your trauma patients to have a pulse. But we should probably be starting with a leader in our traumatic arrest patients, just because they're going to be so profoundly hypovolemic. And this is pretty straightforward. We all know airway management is a priority in any patient, and managing their oxygenation status is. But look at the order. This is first. This is second. In the military, we're taught March, which is a mnemonic to remember which steps we should follow first. And M is for massive hemorrhage. All of this is massive hemorrhage management. Aggressively packaging those wounds, or packing those wounds, placing a tourniquet, unless you don't have any massive hemorrhage that you can really appreciate. If you can't, just place a pelvic binder, move on, have someone bag, do BLS maneuvers with the airway. Get a feel for how they're being bagged. How's their compliance? Is their compliance good? If you've got a basic airway adjunct and you've got good compliance with your bag, you have a high index of suspicion that you're actually providing adequate ventilation. You don't necessarily have to jump directly to intubation or jump directly to placing a kink. Now, if that ease of ventilation is because they have a massive hole in their trachea, they've got tracheal perforation, you need to address that. And one of the other causes that's not always talked about in traumatic asphyxiation is what's called an expanding neck hematoma. And it can be caused by a transection of some of your arteries and your veins inside of your neck. And essentially, it starts to bleed, and then it pushes your trachea and then gradually occludes it. And those are very difficult to deal with. We can't necessarily do that. In the cases where we suspect it, and it'll be pretty apparent, that is a case for rapid intubation. Because it's like a burn, or it's like severe anaphylaxis. It's essentially an occluded airway. So we want to get a tube in, and we want to make sure we manage that airway. So some things are changing in how we dart people. Everyone was probably taught second intercostal space, mid-clavicular line, right? Is that your preferred site? So there have been some pretty awesome studies of, from an A&P standpoint, of CT thickness of chest walls. And what they're finding is that naturally people have more tissue density in the anterior portion of their chest. So it used to be you did needle decompression with a 14 gauge IV cath, right? Well, if you do an anterior decompression with a 14 gauge IV cath, you're only going to actually penetrate the pleural cavity in a meaningful way in about 50% of patients, and sometimes even less than that. The military did a huge postmortem study of soldiers who had tension pneumothorax and had needle chest decompression. and an overwhelming majority of the anterior site with an IV cath failed. And even when you're moving to your longer cath, so the ones that we have on our trauma bags, the 3¼ inch needles, the big lawn darts, even doing an anterior decompression with those, some of those fail. So the preferred site is the 5th intercostal space, mid-axillary. Now that's probably not in the protocol. I'm always going to refer you back to the protocol, but if you look at the evidence and some of the ATLS guidelines and the military guidelines and the other civilian trauma guidelines that are coming out, they're making a move to go here because you have less tissue generally right here, and you can more easily penetrate and know that you're going to hit the pleural space and be able to evacuate the air of the blood that's in there. And then use your 3¼ inch needle. The IV casts are probably not going to work in most patients, especially civilian populations or your older people, or anyone who has a large deposit of adipose tissue. So here's some of your failure rates, 24 to 54%. You have a much lower failure rate with the axillary line. Talked a little bit about cardiac tamponade, and this is a very severe form of obstructive shock. The heart literally can't pump. That's why you're not getting any cardiac output at all. So pericardiocentesis is a temporizing therapy. That means it's buying you enough time to get that patient to the OR so they can deliver the heart from the pericardial sac and make that problem a moot point. And if you strongly suspect it, those patients may benefit from being rapidly transported here to St. Joe, get that blood evacuated from the pericardium, and then sent onward to Lexington. So you do those initial interventions, right? You do your hot. So you address hypovolemia, you address oxygenation, tension pneumothorax, and cardiac tamponade. That's the first thing you do when you hit the door with a cardiac or a traumatic cardiac arrest. After that, what are your decision points? So most of the guidelines agree on this, and it's asystole or PEA less than 40, pretty much gonna die. Accelerated PEA, so a PEA greater than 40, that's organized, has stronger survival. VF or VT, also naturally a very encouraging sign. So after you do your initial, most of the physician statements and the evidence recommends withholding further resuscitation, contracting medical control for termination or resuscitation, and not transporting these people because they're overwhelmingly unlikely to survive. And most physicians, if you call them, be like, hey, I've decompressed the chest, I've given 1,000 of LR or something like that, I've got him intubated or have an appropriate airway in place, I binded the pelvis, I've controlled all the external bleeding, he's still in a systole, or he's in this wide, super slow PEA at 20. I don't think he's gonna, and I'm 45 minutes away from UK. They're gonna be like, yeah, sorry, bro.
Really want to say sorry, bro?
Some of them might. They're pretty relaxed.
Yeah.
Yeah. So if you do all that and you have an organized PEA greater than 40, that's actually a really encouraging sign, because this means that, we don't have ultrasound to verify this, that there's a likelihood that that heart is still trying to beat. It's still depolarizing in a coordinated manner. And there still may be very, very, very small cardiac movements. So what you're doing is working. So when you get to this point, see if you can narrow down your assessments. Figure out maybe what's causing this patient's arrest. Is it more hypovolemia or is it more oxygenation? Or do I need to do a repeat decompression of the chest? Because that may change the game. So this is an encouraging sign. So reassess and optimize the interventions that you've already done. Repeat them as you need to, and then transport. I had a case in Jessamine County where I decompressed a gentleman about 6 times. Because every time I decompressed him, he went into ventricular fibrillation. So he decompensate, we go from VF to PEA, we decompress him, you go back to VF. And this is pretty simple. You still defibrillate your VF and VT patients. This is also an extremely good sign for the patient that's in traumatic cardiac arrest. It's not necessarily a great prognostic indicator, but it's a lot better than a systole. And you follow the same suit as you did before. Reassess, optimize, repeat what you need to repeat, and then get them going. So our ACLS medications, overwhelmingly unlikely to be beneficial. unless it's a crushing. So if you look at the most recent ACLS guidelines and you go through the AHA literature, there's actually no mention of, when you look at your special cases of cardiac arrest management or whatever the header is, of giving epinephrine in traumatic arrest, primarily because it's probably not going to work. Atropine, none of it is meaningfully addressing any of our hot interventions, right? Is epi going to do anything for any of those? Probably not, right? Is atropine? No. Amiodarone, if we have persistent VF or VT, I didn't give that patient amiodarone. I didn't want to, because that's probably not the electrical storm or cardiac arrhythmia is probably not the cause of that patient's arrest, right? It's one of these. So I kept aggressively treating this, and he kept getting better. So use some of your clinical acumen. So I defer to Dr. Jones on what specifically he wants you to do, but our ACLS medications in the setting of TCA is probably not really going to change much. That's all I really had. You guys have any questions, any feedback? This is your time to calm me down.
So is there a time, considering our geographical location, should you assess it on a case-by-case basis, but should there be a time where if the hospital is not going to deliver a meaningful intervention, is there a minimum time that we should stay on scene to perform these procedures?
So there's a lot of conflicting advice out there in the literature. Some say if you have a witnessed arrest with penetrating isolated trauma to the thorax, you should just haul ass to the hospital. But we don't have a hospital that will do the things that increase that survival. They're most likely not going to crack the chest, right? So if you're not in the catchment area, the very close catchment area of like 15 minutes or less of a level 1 trauma center, then most of the advice is to address your hypovolemia, your oxygenation concerns, your tension, your tamponade, and then reassess, because there's not really any sort of purpose to rapidly transporting them to a facility that's not going to deliver that surgical intervention.
Yeah, let me just comment on that. We have good docs and good facilities at St. Joe's Mount Sterling, at Clark, and at all these more rural hospitals in Kentucky. But there's a problem. These hospitals and the providers are focused on taking care of 90 to 95% of what they see, and they don't see much trauma. I can tell you from experience, when you pull out some of these trays for things like thoracostomies and stuff, and you've got a nurse that hasn't seen this in years, and you don't have, they can't find the right stuff, things fall apart, and it's very bad. So I don't think it's a criticism of these small places to say they're not really capable of doing most of the stuff. It's just fact, and it's, back 20 years ago, people used to argue that, oh, go to the closest place, and they've got a doctor, they can know this stuff. And we've pretty well proven that's not good thinking at all. These people, we're talking major trauma here. They belong in a trauma center. They belong where the doctors, nurses, and even the techs are confident. They get the right stuff. They've got it organized. They've got a team that gets together. Years ago, the old Mary Child's Hospital, we used to call in the surgeons for traumas all the time. And that really wasn't very helpful. It didn't make a lot of difference. And it was actually when they didn't have any surgeons that we started saying, take the traumas all to UK. But it was interesting because UK was the first place to say, your patients are doing so much better now that you're coming straight here. And that experience has been duplicated a lot of places around the country. The medical literature now says this stuff doesn't belong at a place like St. Joe's Mount Sterling. That's not a criticism of St. Joe's Mount Sterling. That's just a fact of life. That if you don't do something regularly, you're not good at it. And I can tell you, when I was a young guy coming out of residency, I could drop central lines in 2 minutes. I was so slick and good at it. But today, I hardly ever do that anymore. And I don't want to really be in the position where I've got to do it right now for that trauma victim. And it really makes me feel good that we've proven a lot of other things will buy time. But if you bring this person in that needs a cardiac tamponade to St. Joe's, that you think has a cardiac tamponade to St. Joe's Mount Sterling, they're probably going to package them and ship. They're not going to stick a needle in your chest. And I'll tell you one of the reasons. When I was training, the way we did a needle thoracentesis of a pericardium was we hooked our EKG machine to the needle. We used a long metal needle, and we went in and we watched the pattern on the EKG machine. Well, EKG machines aren't made that way anymore, and those needles are not readily available anymore. The equipment just isn't there to do it like that. And when you try to fuss around with what we have today, it's not so good. Actually, today you do it with ultrasound guidance, and that's a lot better. But if you haven't done that before, you're not going to be proficient at it. Or if you've only done it once or twice in your career, you're not proficient at it. So I just really want to say it's not worth, or it's worth losing 5 or 10 minutes to get straight to UK and bypass the local hospitals with almost all the major traumas. It's a rare situation where you're going to help the patient by stopping it. And I don't think I'm criticizing them when I say that. It's just a better system.
I have another question.
Okay.
I know spinal immobilization in a patient with penetrating trauma who's alive worsens the outcome. Does that apply to traumatic arrest?
Not really, because like think about our priorities, because they're in traumatic cardiac. We have other things that we really need to address to try and reverse this arrest. If they have a really convincing sort of presentation, you can address that concern after you follow your initial resuscitation. But me personally, I would be more focused on what is causing that arrest and correcting that problem, and then working back to C-spine, which would probably be somewhere near the bottom. Now, if we suspect that this is a hypovolemic arrest secondary to like neurogenic shock, then we might have a case for C-spine. But that is probably going to be a fraction of a fraction of a fraction of most of your TCAs out there. So I honestly would just put them on a scoop, and that would be my spinal immobilization, and just make sure they're down nice and tight. Another thing I want to say is, how many people have heard that the lupus is contraindicated with traumatic arrest? Okay, I think that has actually been okayed by physio control now to use it in traumatic arrest, as long as you're not exacerbating the injury too badly.
I think they initially said it was just because they hadn't had a chance to really evaluate it.
Yeah. So that's a good force multiplier. And if you do the mid-axillary decompression, that keeps their arms up out too. So,
Use a little judgment too. If your choice is to do something but pronounce someone dead, what's the harm?
So you're saying we can do pericardial?
Probably we have a long enough needle.
I'm watching.
We can do one in me, but not in cheek. We couldn't before. But I would love to have you guys do pericardial centesis. I don't think it's that terribly hard. I'd like to see you have ultrasound in the field. It's not realistic right now, but we're living in this world still.
But the takeaway point is, more of these people survive than once previously thought, or maybe even previously taught. And there's some select interventions we can do that will greatly increase the odds of that patient's survival, if that was survivable to begin with. Because we're kind of starting with a blank slate, and then using those interventions to rule in or rule out what may be. Because if you have that massively injured patient, there's so much going on that it's really hard to tell what's the most exact cause of that patient's arrest, where you can really focus on your treatment.
And
So,
remember too, there's the obvious problem, but you need to think, what is happening that I can change? And that's where your efforts need to go.
anything else?